Hey everyone, my name is Dave Supek, Co-Medical Director for the Twin Cities Marathon with Dr. Jake Kastner. Thank you for joining our 43rd Medical Volunteer Lecture this year. I am so very appreciative that you are not only taking the time to volunteer for the marathon weekend, but are really going the extra mile to prepare yourself for race weekend by watching these videos. This year we will divide information into two distinct sections, which you can watch at your leisure, which Dr. Jake will tell you about now.
Yeah, so we got two different videos to watch here that are going to detail some of the logistics that you need and some of the common pathology and some of the common issues that we deal with on the medical team. So the first video is going to be for medical volunteer logistics. This is your who, what, when, where, and how on everything you need to know for race day. When to show up, how to prepare, who to talk to, phone numbers, important stuff like that. It's a comprehensive look at the preparation for the race day. The second one is going to involve a lot of our common medical pathology and include some of our algorithms from World Athletic Medicine to go through our most common treatment plans so everyone feels prepared to help our racers on race day.
And our lecture will be held here today by our University of Minnesota Sports Medicine Fellow Physicians. First, we're going to hear from Dr. Alyssa Goldstein, and then the second module will be led by Dr. Nirmal Maxwell and Dr. Audrey Potts. So after watching these lectures and internalizing the slides, if you have any other questions, please don't hesitate to reach out to myself or Dr. Jake or any of our presenters today. We're happy to help you from now through race day.
All right, hey everyone, my name is Alyssa Goldstein and I'm a primary care sports medicine fellow at the University of Minnesota. So this first slide is really just a slide for reference for you, just about start times, course closure times. So if you're able to, I would go ahead and just take a picture of this so you have it at your convenience. This is a course timeline. You should have it available in the PDF. But also this is just where we expect people to be at different times on the course, kind of a broad scope of that. Another picture just for reference in regards to the state capitol grounds in that finish area. Specifically, we will be honing in on this more yellow area on the right side of the finish map, as that is where the medical will be focused. This is the 10-mile course map, followed by the half marathon course map and the marathon course map. So please take pictures of these and you should be able to find them pretty easily online too. So talking about the medical aid stations, we will have many medical aid stations along the course, but we will also have our full medical care at the finish line. We have these red tents and red medical flags. And so along the course, we will have comfort care things available for our runners. That'll include first aid shelter, but we will also be able to cool people down with the ice and taco method. Volunteer medical identification. So those outside of the big medical tent will have orange vests. We will have blue volunteer shirts for the medical tent and finish area passes for our medical volunteers. And then along the course and all around, we will have people in yellow shirts for medical communications. Our course aid stations, we will have every 2 miles up until mile 22, and then we will have them every mile. Part of that is we will have fluid and fuel available at those stations. Something we do take into consideration is just trying to avoid hyponatremia along the course. So we don't want to have too much access to water to the point where that could be an issue. But we do have fluids available at those different stops. And then all along part of the medical team, we will have a whole bunch of different players, I will call them, but we will have physicians, RNs, APPs, medical students, PT students, physical therapy. We'll also have BLS and EMTs. And kind of like I mentioned, we will have fluids and fuel along the race. These are our medical aid stations, and you will probably want to take a picture of this as well, especially if you know kind of where you will be and which aid station you will be at. So these times are the times that we expect runners to be coming through, but those aren't necessarily the times that you should arrive. You should arrive before this because these are the times that we do expect or anticipate that we may need help providing medical care. Our first aid station. So in addition to those medical tents along the course, we will also have a few different teams out there. So one of those is the National Ski Patrol, and those are EMTs. They'll be located at the mile and half mile marks and miles without medical aid stations. They can provide first aid, and they will be able to communicate if a higher level of care is needed. They do not have AEDs. And then we also have the National Mountain Bike Patrol, and this will be pretty cool because they will do rolling assessments. So they'll be able to be up along with the runners. They do have CPR capabilities. They can, again, talk to others if there's an escalated need for medical care, and they will be operating in pairs. We will hope to have 4 teams of them this year. So at each medical station, there will be these boxes, and what's in them? So we have, for cardiac chest pain, we have aspirin. We'll also have an EpiPen and Benadryl if we need those, and then glucose tabs and gels. We don't have any NSAIDs, acetaminophen. And in addition to that, we do have some smaller things that we might need. So garbage bags for rain jackets, Mylar heat sheets, and then anything feminine needs. The heat sheets, for those of you who have run marathons and gotten these before, you probably know how they work, but if it's cold out, you want that shiny side facing in, and then if it's hot out, you want the shiny side facing out, and we will have those in the boxes if we do end up needing them. Transportation along the course, so these yellow school buses are for runners who are not medically impaired, but do still want to drop out from the course. So these yellow school buses will take runners who have dropped out to the finish line. And they can be used as warming huts, and they can be a wait time. So just because somebody gets on it does not mean that they are automatically off or disqualified. For ill or injured runners on the course, we do have a couple of different levels of care. We will have the mobile ALS ambulance for transports. These are provided by Hennepin Health and the St. Paul Fire Department. And then stationary BLS community ambulance, and that's at the aid stations. It can be good for ill runners. And then it's really good for just if we have a lot of people who aren't doing well, to give them a place for shelter and to help them out. Communications, cell phones, handheld AM radio, and then these are the channels that we will be using. Finish area, we will have, that will be the area for central dispatch for the course. We will also have the field hospital, cell phones, and then the triage teams will have radios. This slide, please take a picture of it. These are numbers that hopefully you don't need, but you might end up needing. So, of course, dial 911 if you need the ambulance. Medical emergency phone number, that is here. And then the runners should be in the Race Safe mobile app, and that will have their medical information, emergency contact. And then at the bottom, we have the non-emergency number, which you will also want to know. These are just things to report when you are reporting that a runner is down or ill on the course. Course closure, so the slowest pace that somebody can go is 13 minutes and 44 seconds per mile. After that, then they may get swept up by this bus, the sweep bus, and those will just pick up the slower runners and take them to the end of the race. And this, excuse me, unlike the other buses where people could wait if they really needed to, this one, this is the official end of the race. All right, so we want to focus on competitor safety, community safety, and then hopefully we don't run into any disasters. This is the finish area. It's a pretty good picture for reference again, and then just again focusing on that yellow area on the map, as that is where we will be, and then this is just showing you where different places will be. All right, and then in the finished area staffing, kind of like I mentioned before, this is who will make up the different teams there. So we have physicians, nurses, paramedics, EMTs, physical therapists, athletic trainers, students of different kinds, first aid personnel, and youth volunteers. This is a better picture of the secure finish area. So over on, within the purple box on more of the left side, we have the finish chute. And then there is a red box, which will be the medical tent. And then the green square is the medical information tent. So that is where we will be when you go to check in or meet everyone. That is where you will want to go. For finish area transportation, keep your head up, especially if you are at that finish line. There may be wheelchairs in different places. We will have motorized carts if necessary, but we also may need some people who are just needing some assistance walking. So there could be a congested area, and again, just keep your head on a swivel. And then also at that finish area, we will have ambulances, ALS, but ambulances really if anybody needs to be transported. This is what the inside of the medical tents will look like. And this is a diagram of it. So here is, you obviously have the entrance, you have a small lab, the supplies will be in the middle. And then you have these stations in the blue boxes where the different teams of medical personnel will be. And within each of those, you will have, let me back up. Oh, I can't back up. Okay, well, within each of those, there will be 4 cots where we can do evaluations and treatment. And at each of those 4 cots, or at each team, there will be a whiteboard. And that whiteboard is divided into 4 sections for each of the cots. So basically, you will want to write down the number of the person, the bib number of the person who is at a specific cot, just so we can keep track of everybody. But the important thing when you're writing something on the board at these cots is to not erase the number, but to only strike it out. We never want to erase the bib number once we've written it down when the person is over at their cot. And the reason for that is we want to make sure that we keep everybody accountable. Nobody goes missing. We don't lose anybody. So that is important. Sorry, I skipped over that slide, but moving on. In the medical tent, these are the things that we will have. So pretty standard. You've probably been staring at this slide for a while now, but we'll move on. And then these are more supplies that we will have in that medical tent. An important thing is we will have D5 normal saline, and then typically, at that point we're checking glucose. If the glucose is under 100, then we'll do more D5, but if it's over 100, if somebody needs a second liter of fluids, we will be giving normal saline. These are some medications that we will have available. Again, they are somewhat limited, but we do have a lot, and we definitely have the important ones. So cardiac meds, albuterol, an EpiPen, Benadryl, and then our IV fluid, some Zofran. Race Safe, there will be a separate presentation for more information on Race Safe. So I'm going to go ahead and skip over this one. And then, so this is when you would send somebody to the emergency facility, not responding to usual treatment, severe casualty that is not responding rapidly to initial treatment. And then if somebody has cardiac chest pain, we're sending them. Shock, absolutely sending them. If their temperature is over 107 degrees Fahrenheit, ideally we will cool them. Any exertional heat illness, as Dr. Potts and Maxwell will talk about later, we do want to cool them first, just because we have the ability to cool them there on site, and if we go ahead and transport them, then they may not be able to be cooled as quickly as they would if they stayed to be cooled. Please ask for additional information from the providers who have worked at these events before if you have any questions about that. And then transfer criteria, if somebody has blunt trauma, we are also transporting them. Discharge, excuse me. So if somebody is clinically stable, normothermic, and ambulatory, we will go ahead and have them sit up. If they're sitting up and they are doing okay, they're not feeling lightheaded, we can go ahead and have them stand up, and then we can get them moving on out. If at any point in time they're feeling lightheaded or giving any signs of orthostatic reaction, then we will not discharge them. We'll have them continue sitting and continue treating. And then when people leave, we want to make sure they're continuing to eat and drink, and then give them follow-up recommendations and when they should return for further evaluation. So people are not going to be disqualified for seeing medical care along the course, but in order to proceed, they do need to be oriented to person, place, and time. They do need to be able to run in a straight line with good competitive posture and look clinically fit. These are the report times. Again, another reference slide for you. This is parking information. Reference slide for you again. And then volunteer transportation. So you can use the Metro Transit for free. Equipment return. We will be able to go over this once we are all together, but we basically just want to take anything down that we put up, and that's all I have to say about that. We will talk about what went right, what went wrong, and then changes. So if you see something along the way, please make note of it, even if it's just in your phone or whatever you think is appropriate. And then we can talk about it later. We would love to make this even better. For the volunteer evacuation plan, this is hopefully not something we will run into, but this is just what our plan is. And if something does happen, I would say the big thing here is, of course, you're going to notify the medical director. But a bigger piece of this is we do not want to discuss specific events, specific patient identification. We would like to be as HIPAA compliant as we can. And we do not want anything on social media. Please don't go ahead and start recording the events. We do just want to keep everything under wraps. This is our medical ops committee. All right, so in healthy runners, we have a lot of healthy runners. What could really go wrong? What are we really going to see? Well, we have between 8 and 100 per 1,000 participants have a medical encounter. Most are pretty, I would say, lower jeopardy or self-limited, but we do have some more stressful or more acute problems that we will see. And different risk variables will play into that. So weather is a big one. Rain, heat, cold. There are a lot of things that can go into that. We look at the participants, their fitness, their health, and their pace. And something that plays into this is just, how acclimated these athletes are to whether it's the heat or the humidity. That could certainly play a role in the different variables. Natural disasters, and hopefully not terrorist activity. Death in marathon, so cardiac arrest, it does happen. If somebody is over the age of 40, it's more likely coronary artery disease. If they're under the age of 30, that it's more likely a cardiac anomaly. And we do want prompt defibrillation. Something else that we do see that can cause death in marathons would be exercise-associated hyponatremia. So I briefly mentioned this earlier, but runners, especially those who have not experienced as many marathons or as many distance events, they may overhydrate and not get enough sodium. So that is something that we can worry about just to make sure somebody isn't hyponatremic from overhydrating and just not taking in enough electrolytes. Hazardous conditions, these are all things, lightning, heat, cold, wind chill, wind, traction, air quality, and flood. And hazardous conditions, there are different levels of how hazardous the conditions are. So at its worst, and when we would cancel the event, would be if conditions are so bad that they are in that black zone or the extreme zone. And then just kind of going from there, there's high, moderate, and low risk for the conditions. And we will have a flag system for this along the course. And these are the flag colors. Ideal conditions for this marathon, we'd like it to be in 40s to 50s. Cloud cover for the elite, and then a little sun for the slowest runners. And usually we are in this range for the average high and low temperatures. So hopefully that will be the case for this year as well. So we do see a pretty good number of injuries. We'll move on from this, but these are some numbers of injuries that we see. We see obviously a lot more heat illness and injury when it is very hot. So hopefully it'll be pretty cool this year and we just will not see a lot of exertional heat illness or hopefully fewer injuries, but going from that. This is from the Twin Cities Marathon in 2007. It was very hot that year. We had significant amount of heat illness, so significant that the mass casualty event or incident criteria was surpassed, and it was the wet bulb globe temperature was 81 degrees Fahrenheit. So just something to think about, and we can contrast that with, this is when we would talk about do not start. I'm gonna actually keep going down from here. When it was cool out and we had significantly fewer exertional heat illness, and overall things went much better. There was a case of hypothermia, but otherwise just fewer people who dropped out. Okay. Cold and wet conditions, we will see increased risk of hypothermia, especially in the slower runners. The faster runners produce more metabolic heat and the slower runners may not. So.
All right. My name's Dr. Audrey Potts. I'm one of the other primary care sports medicine fellows, and I'll be taking you through part of the section of the medical protocols lecture, and my colleague Dr. Maxwell will also jump in and help out with this section of the lecture. So we will kind of be going through the most common medical issues or emergencies that come up during the Twin Cities Marathon or long distance events, just to better prepare you for what to expect if you were to run into something like this while at the event. And we'd rather you know beforehand prior to just going blind and figuring it out as you are there. So from a medical protocol standpoint, we'll go through some of the first aid of it. First and foremost, the goal is obviously to do no harm to your patient, so keeping that in mind throughout the whole process if you do evaluate an injured athlete. And then it's also very important to know your roles and resources. And these are kind of the questions that you should be asking or knowing prior to going into the race. So for our documentation and diagnoses, we're going to be using the RaceSave medical record. So just make sure that you have that app and access to documentation. Obviously want to complete and record all of the following whenever you evaluate a patient. So we'll be kind of going through the collapsed athlete, and just as a general overview, typically if an athlete has collapsed before the finish line, usually that means an essential organ system has failed or is not functioning. So some of the main causes would be something like a cardiac arrest, exertional heat stroke, hypernatremia, insulin shock, anaphylaxis, kind of these more major serious events. And then after the finish line, typically what happens is after severe exertion of energy, your muscle pump when you finish just kind of collapses, and your body kind of shuts down. And some big causes of this are exercise-associated collapse, which, as we'll talk about, is more of a diagnosis of exclusion, and then exercise-associated postural hypotension. These are some nice guidelines if you want a resource. It's what we've used to create some of these slides. Now, we're going to have a lot of medical algorithms through this part of the talk. what I'll do is kind of quickly go through the main points of each one. And so for the collapsed athlete triage, really the biggest thing is are they unresponsive? And if no, do they have a pulse? Next, you're going to assess mental status. And if they all are altered, you're going to ask, are they hot? And that will be an immediate rectal temperature. If they're not hot, then are they hyponatremic, so low sodium? And those are kind of the big things that you want to be just kind of cycling through your brain as you assess a collapsed athlete. And feel free to definitely go through this algorithm multiple times so that you have a good understanding of what to do. So here are some of the things that we're going to talk about today. So first we'll go through the cardiac arrest / pulseless athlete. Then we'll talk through exertional heat stroke, hyponatremia, and then exercise-associated collapse, and some of the main things that we should absolutely do. So first, for a patient who has a potential cardiac arrest, this would be a cold blue for down if there's no response. If you have checked and there's no pulse and they are down and they are not responsive, you are going to automatically start CPR with good quality chest compressions. We're going to call the code teams and 911. And then, these TCM modifications are basically, if we find that there's a certain cause for a cardiac arrest, then we're going to replete what we need to replete and use epi if needed as well, epinephrine. If someone's complaining of chest pain, we're concerned about kind of acute ischemic event, then we have access to aspirin, 325 milligrams, oxygen place AED as soon as possible. And if there's a trauma situation, we're going to go down the ATLS protocol. So more for a cardiac arrest specifically, this patient's going to be collapsed, unresponsive, and no pulse. And the immediate treatment, we usually kind of go with the ABCs, but with a cardiac arrest, we think about immediate compressions, then securing the airway, and then giving breaths. So really the emphasis is more on chest compressions. And then we're going to get the AED as soon as possible to set up the pads to evaluate the rhythm. And this is kind of the main reason for this slide. And obviously you want to activate EMS as soon as possible. And this is a kind of a more dedicated algorithm for cardiac arrest. This is mainly based off the BLS algorithm. So please go through this a few times just to make sure that you kind of remember in your mental cycle of how to deal with a pulseless collapsed athlete and your kind of basic BLS treatment for that. This slide is basically to show how important it is to have fast access to an AED and how speedy placement of the AED pads can really improve survival with good neurological outcome. So as I kind of mentioned, CABs instead of ABCs. Compressions are going to be hard and fast, and you're not going to stop. And you're really going to work hard to make sure that these are good quality. And then electricity is really, really important. As you can see on the diagram here, is there's the proportion of survival with a good neurological outcome in percentage with a defibrillator and with bystander CPR, and then defibrillator without bystander CPR. It's certainly significant improvement there. So making sure that all of these three major things in a pulseless athlete are taken into account. This is just another slide to show that the time to AED pad placement worsens the chance of survival if the time is increasing. And so the faster we can attach those pads, the better.
Hello everyone, my name is Dermal Maxwell and I am alternating this medical talk with Dr. Audrey Potts. So next I will be talking about exercise-related heat illness. So if you've covered races before, you may have heard of some of the classic diagnoses such as exertional heat stroke, heat exhaustion, heat cramps, heat syncope, hypothermia. There are a couple of now quote-unquote new diagnoses. These are just a little bit more specific terminology that we use. So exertional heat stroke is still very commonly used, but instead of heat exhaustion, heat cramps, and heat syncope, they're a little bit more specific and not, based on just a patient being overheated to cause the symptoms with exertional hyperthermia and exercise exhaustion, as this can also be associated with normothermic exercise-associated collapse. So this next slide here is just to give you an idea of how our body is able to react to heat in itself. So as you can see by this kid who's sitting on a bench here, he is getting heat from solar radiation itself. And what you should take away from this slide is that our body, our muscle itself produces heat. 70% of that energy is produced by muscle during activity, and our brain and the hypothalamus regulates our body temperature. So in order for us, as we process heat from our muscles itself and from solar radiation, is our ability to cool ourselves off, and that happens through sweating. It's not just the actual ability for us to be able to sweat, but the actual evaporation of the water itself. We lose up to 1 to 2 liters of 1 to 2 liters of fluid per hour during sweating. Now, one of the biggest factors to determine how well someone is able to sweat or effectively cool themselves is humidity. So the greater the humidity, the more difficult for the body to cool itself. And you may not be able to lose that heat into the environment like that last slide. How we measure this when we are talking about race conditions is the wet bulb globe temperature. So this is an accurate measure of environmental heat stress. So similar to like what Dr. Goldstein was talking about, that this marathons can be a mass casualty event. The wet bulb global temperature is very important for us to be able to track, and it can be used as a primary risk reduction strategy for exercise in the heat and for making activity modifications as the wet bulb temperature rises. So how do we calculate that? This is the equation here, and the biggest takeaway is that 70% of this equation factors in humidity. It also factors in solar radiation and air temperature itself. The American College of Sports Medicine, ACSM, has a position statement saying that the do not start for marathons would be a wet bulb globe temperature of greater than 82 degrees Fahrenheit. However, Dr. Rob Johnson has done plenty of research as well in saying that depending on the location of the race set itself, whether it's at higher latitudes, plus unexpectedly warm conditions, plus participants are not acclimated to it, consider a wet bulb temperature of greater than 69 degrees Fahrenheit. So here's a map dividing up the US in 3 different categories. And the purpose of this slide is just to show you if it's different, for running a marathon in, say, for example, Miami, Florida versus us here in Minnesota. We're in 2 different categories. Here's another table. Again, this is just to give you more of a reference of why we keep track of the wet bulb temperature and what that looks like for the different categories itself. This is in Celsius. The 24.6 to 26.7 that you're seeing here equates to about 76 to 80 degrees Fahrenheit in our region for continuous activity. And as you can see, there is quite a risk of having that temperature be that high in itself. Here's just another graphic just to show you the importance of that temperature and how soon people can experience these symptoms. So exertional heat stroke. The definition of exertional heat stroke is hyperthermia, temperature greater than 104 degrees Fahrenheit. This is associated with central nervous system disturbances plus multiple organ system failure. At this point, almost all exhibit sweat-soaked and pale skin at the time of collapse. That's something to keep in mind, in contrast to someone who has non-exertional collapse related to heat stroke, where they are dry, hot, and have flushed skin. So there are a couple of predisposing factors to exertional heat stroke. This would include strenuous exercise in a hot, humid environment, lack of heat acclimatization, and poor physical fitness. The greatest risk, as I've said before, is that wet bulb temperature being greater than 80 degrees Fahrenheit in that category 1, and high intensity exercise for our runners in itself, greater than 1 hour, greater than 75% VO2 max. This can still occur in cool to moderate environments. It comes down to how well acclimatized you are to the heat. And what's important to note is this is 100% preventable just with understanding what that wet bulb globe temperature is, and also just the different risk factors. There are several famous, unfortunate examples. The example here being Corey Stringer from the Minnesota Vikings, and also Jordan McNair from the University of Maryland. So how do we treat exertional heat stroke? Well, it requires teamwork, coordination, and vigilance. It's a very active process, and it's a very quick process to be able to diagnose this. If you suspect that a patient has hyperthermia, we have to act pretty quickly. The most important thing is first, move into shade, remove excess clothing, and getting a rectal temperature. That is one of the most important steps, is getting that rectal temperature. If you see that temperature is 104 degrees, they need active cooling immediately, which could be from ice water tub immersion, rapidly rotating ice water towels to the body, and ice packs and the neck, axilla, and groin. It requires acting very quickly. We also want to make sure we're monitoring the temperature every 10 minutes, 5 to 10 minutes, and to cool until they wake up or shivering, and that temperature is below 102 degrees Fahrenheit. So why do we use the rectal temperature? This is a really important slide to just show the variance that you get by using forehead temperature. So as you can see from here, a rectal temperature of 108 degrees Fahrenheit, which is really high, compared to someone who's getting a forehead temperature, that range could be 98 to 108. So it's very important that we get that temperature. So there are two different methods that we have for rapidly cooling them. There's the taco approach and the tub submersion. So starting with taco approach, we use tarp, ice, water. We essentially have the runner that will be in the tarp itself. We are dumping the water and ice there, and you see multiple people are holding it there to help the water move through as it's going through, and they're stuck in that position. Tarps will be available at all the medical aid stations for the taco method. And the tub submersion, which you may be more familiar with, that's available at the finish line as well at the 20.8 miles. There's 4 to 6 that will be at the tubs at the finish line, and then about 2 at that 20-mile mark. And the tub submersion is having them in the tub itself. There'd be ice, water, and then you'd be placing waters all along like the armpit, the groin, the neck, multiple different areas, and rotating that through. So what are some of the signs and symptoms of exertional heat illness? So this is a long list here. The most important thing to take away is, again, heat illness or heat stroke, as we're seeing it, it is multi-organ failure. So you're seeing multiple parts as you're looking here. But the quick things to keep in mind when you are triaging these patients, one, as you're seeing them initially, do they have a pulse? Okay, the next step is then assessing for exertional heat illness. So checking that rectal temperature, checking for delirium, seeing if their mental status has changed, asking them if they know their name or where they are at right now, just talking to them to get a sense. And if you have that suspicion very early, get that rectal temperature and we'll go ahead right away with the immersion. This is a really good algorithm to break through. I won't be going through it in depth. This is something to pause the video to read through this. I think it goes through it step by step. Really good protocol. We will also have this in the medical tent as well for you to review at your own free time as well. But definitely pause the video here just to take a look, and definitely rewatch this part before you participate on event day. Switching gears to hypothermia. So in comparison to hyperthermia, this is maybe not as common, but something to keep in mind. So this would be a temperature of 95 degrees Fahrenheit. How do we treat this? Well, remove wet clothing, dry the skin, and begin warming protocols. We do have pre-warmed blankets that can help insulate, and placing warm packs in those same areas we were placing the cold packs before, in the neck, axilla, and groin. And consider monitoring their hydration status and monitor their temperature, maybe not as frequently as the 15-20 minute mark. And again, here is the algorithm to follow for hypothermia. So please feel free to pause this and come back and look at it at your own time. Moving on to exertional hyponatremia, low sodium. So serum sodium less than 135 is considered hyponatremia. Now there is quite a range, which I will talk about with hyponatremia, but anything less than 135 is considered hyponatremia. And this can be a life-threatening condition. It's caused by overhydration during marathons. So people who were taking in too much fluid during the race and maybe a little bit slower, fluid without any sort of salt or sodium intake will cause hyponatremia in these cases for runners. So how do we diagnose this? We do have eye stats in the medical tent so we can check to see what their sodium level is. Sodium levels can range from 110 to 135, and this can happen if the runner themselves is maybe they're telling you this. They drank multiple glasses of water at each water stop. They maybe were initially very mildly symptomatic, and then they notice some muscle cramping, some headaches, a little bit of nausea. Those could be some of the mild symptoms. However, this could rapidly deteriorate, progressing to seizure, respiratory distress, coma, and even death if it's not caught early. So, like I said, some of those early symptoms, they may feel lightheaded, they may feel dizzy, they may have a headache. That can progress pretty quickly to vomiting, dyspnea, they're feeling short of breath, or confusion. So some of these are similar things that mimic heat illness. So going back to, again, checking, do they have a pulse? And checking for those signs and symptoms worrying for heat illness. If they kind of pass through those two things okay, this is the next thing to consider is hyponatremia. And that late stage would be, if they were to have a seizure or they're even more confused than they were before. So like I said, we can check an I-stat. So that's sodium. If we see it's below 135, mean sodium for an obtunded patient, someone who's very altered, can range from 121, give or take 3. And again, like I said, there's quite a range. And there could be other causes to why their sodium is that low, such as their glucose being elevated, or their hematocrit in BUN is decreased due to overhydration. So how do we treat that? We get that initial I-stat itself. The first thing we do is when we closely observe them, and second, we give them salt water in the form of bouillon cubes in water and have them drink that PO. If they're still symptomatic or they're, say, for example, worse, this would be where we'd consider 3% saline, putting an IV in there and running that over 10 minutes and rechecking and seeing how well they're doing from that perspective. We would recheck with that I-stat. If it's not getting better, and honestly, if we're already putting an IV in them, they should be heading to the emergency room. Exercise-associated collapse.
The next thing we're going to talk about is something called exercise-associated collapse. In general, this is a diagnosis of exclusion, but can be defined as an inability to stand or walk unaided during or after an endurance activity. And there's no other medical, orthopedic, or dermatologic reason for the collapse. So it excludes all the sort of main reasons why athletes could collapse as listed here. And typically it's classified by their rectal temperature and their sign and symptom severity class. So some potential causes of EAC are contributing mechanisms. As we said before, this sort of so-called loss of muscle pump and vasovagal response immediately after exercise, peripheral vasodilation, dehydration, depletion of energy stores, so low glucose, and then the central nervous system failure, obviously at the more extreme end. Some common signs or symptoms, as you can see, they're pretty generalized and non-specific, but can include extremes of hot or cold, exhaustion, lightheaded, cramping, some stomach issues, and then signs you could have an abnormal body temperature, your mental status could be changed, you might not be able to walk, you're having some belly or abdominal signs like vomiting, diarrhea, that kind of stuff. So just think of this in the back of your head when you don't have a specific diagnosis for someone's collapse, but they're appearing still pretty kind of unwell. To make the diagnosis, you have to have presence of the symptoms and signs. And then the major criteria include your body temperature, mental status, and ambulatory status. So here's the classification matrix. So classified into mild, moderate, and severe based on temperature, as you said, as you can see here, and then symptoms and signs. So you can kind of see the mild temperature ranges, obviously get worse as you get more severe. And then the symptoms, as you can see in the mild situation, they can walk alone, versus severe, they're unable to walk. Vital signs are typically also worsening in severity as you kind of go along the spectrum. And that's how you kind of classify the exercise-associated collapse. Really, the management depends on what you're treating. So obviously, you really want to make sure that you're diagnosing and documenting exactly what's going on. We're going to talk through fluid redistribution and replacement, temperature maintenance and correction, energy replacements like glucose replacement, and if the patient's recovering or if they need to be transferred to higher level care. As you can see in the image here, this will be how the tables are going to be set up in the medical tent, where the feet are going to be kind of elevated and the heads are more towards the center of the medical tent. And this is for a specific reason. So when you have someone that you feel like their exercise-associated collapse is related to fluid, the first thing you're going to do is, or like dehydration, the first thing you're going to do is have their legs elevated and their buttocks elevated, as you can kind of see in this lounge chair here. Then you would start by replacing fluids. Typically oral fluids is preferred, but if necessary, then we would have to start an IV. First liter is typically with D5 normal saline, and the second liter can be normal or D5 normal saline. Now, if you think the exercise-associated collapse is related to changes in blood glucose, you definitely want to check this level prior to starting any fluids, because that can falsely change the blood glucose level that you're treating. You can use a portable glucose meter, typically at the great toe or the earlobe site. So something to keep in mind, and we'll be able to have these in our medical tents. Now, this is kind of a nice sort of slide to decide who actually gets IV placed if necessary. So a big situation is if you feel like their fluid status is low, and they have not improved after like trying oral fluid replacement after their legs have been elevated for 10 to 30 minutes, and they're still having symptoms including orthostatic blood pressure drop after leg elevation, blood pressure less than 100 systolic and symptomatic, you're having tachycardia and severe temperature range. You'll also want to give an IV for people that have severe muscle cramps or muscle spasms. Typically, anything that kind of goes above into the chest and full body, you want to start an IV and get fluids in them as soon as possible. For people that are really dehydrated, not eating, having nausea, vomiting, diarrhea, that's pretty severe, we want to give them an IV. Severe hypoglycemia, less than 60, if they're confused, and then, if you need medication access, or if you're still, I don't think they're doing well, based on clinical judgment. So here's again a nice schematic of exercise-induced or exercise-associated collapse. Basic sort of standard algorithm here, but making sure that you're kind of reviewing this first, placing the patient supine, assessing the mental status, and from there, that'll kind of dictate your next steps. Typically, it'll include a hydration status, checking your rectal temperature, glucose, and ISAT, that kind of thing. And then you'll kind of be able to go to a certain protocol based on what they're presenting as. This is another sort of slide as to guide you to who needs IV fluids, as kind of mentioned on the previous slide, but this is kind of a nice schematic as well to have to go through if you're worried about a patient who might need some IV fluids. Okay, we will now start talking about exercise-associated muscle cramps.
All right, moving on to exercise-associated muscle cramps. So this can occur during or after intense exercise in the heat. Core temperature, if we were to measure it, would likely be normal or less than that 104-degree cutoff of what we call for heat stroke. Signs and symptoms could be involuntary muscle twitches or fasciculations. Might be just seeing a little bit of that twitching happening. It can be very painful in a couple of different muscle groups. It's most commonly affecting the calves. However, you could get them higher up in your legs or also in your upper body too. Typically, they last 1 to 3 minutes. However, they can be very uncomfortable and could last up to 8 hours and go on and off. How do we treat that? We treat it by first really encourage hydration. That's the first step. So hydration and resting the muscles. We want to avoid massaging until they're pretty well hydrated. So we do have lots of physical therapists and PT students volunteering that can help be able to do a couple different techniques to help with the symptoms itself, but first promote hydration with those salted fluids and the rest muscles. And then slowly, like the physical therapists and the PT students can work on having them walk, assist in the walking. So what we can also provide, if it's still not getting better, is we can give them IV fluids, such as normal saline or D5 normal saline. If they're not getting better, it is important to consider sending them to the emergency room if we're concerned for rhabdomyolysis or extreme muscle breakdown. Here is the algorithm you can go through for exercise-associated muscle cramps. Moving past that, we'll talk about sprains, strains, and contusions real quickly. So, of all the things we've talked about, all three of us have thrown quite a bit of information at you. This is a little bit lower on the priority in comparison to the cardiac, the heat illness, the cramps, the collapse. This is a lot lower on the pecking order. So what do we do for all of these? Well, rest, support, we can give them crutches, have ice, compression elevation, all of those RICE techniques. If we do suspect a stress fracture, again, we don't have x-ray on site. So again, talk to the patient, assess them. Again, can tell them about doing RICE, all those things I just said in the previous slide. Give them crutches. And if they want to be evaluated right now, if it's really bothersome, you can tell them to go to the emergency room, or they can see a primary care physician, their primary care physician. Blisters. This is a very common thing you'll see for these runners. So the most important thing is evaluate the blister itself, see where it's located. It could be anywhere on the foot or any other part of their body. We want to make sure we keep this area clean. Typically, we don't like to drain these just because 1, the fluid can build back up, and 2, it's an infection risk. So we want to make sure to keep this clean. We'll have bacitracin ointment and then cover it, whether that's with tape, adhesive bandage, something just to cover it and protect it from bursting open. Now, disposition. So our goal, again, is to initially triage these runners to see what they need right in the moment, and then eventually decide whether or not they can be discharged home. So the patient that can go home are the ones that we think are clinically stable. We figured out what the issue was, and they've gotten significantly better. They're now normothermic, they're back to regular temperature, and they're able to walk and they're ambulatory. The sit test here is seeing that, hey, are they able to sit by themselves? They're comfortable there and they're able to walk. So if you're not sure if they can discharge home, we can have them walk around the tent and see how well they're doing. Apart from discharging home, we may have to transfer them to the emergency room. So they're not responding to the usual treatment. If we have EMS involved, there is a high chance they are going to need to go to the emergency room. But automatic transfer criteria would be cardiac chest pain, if we're concerned for shock, their temperature is still 107 degrees Fahrenheit, still very elevated, any sort of blunt trauma, and then a sodium that's less than 125, and they're still very symptomatic. Something just to keep in mind as you're taking care of runners itself is just bodily fluid precautions. We do have gloves there, so sweat is not necessarily a problem, but there is always a risk for blood and other fluids, so make sure to have gloves if you are checking a sugar or checking an ISAT, because we do not want to spread any blood-borne pathogens. And we do have sharp containers there as well to be able to place the sharps. So in summary, again, Dr. Potts and I threw a lot of information at you all. But the most important slide, I would say, other than just the algorithms themselves, is this slide. And really thinking through as you're seeing seeing the runners, is going through this in your head. First off, is there a pulse? If there is not, think cardiac arrest, think of the CABs, and go down the algorithm. Okay, they have a pulse. Are they hot? Are they showing symptoms of heat illness? Do not hesitate to get that rectal temperature. That can save someone's life and really make sure we know we're doing the right thing by actively cooling them. And it's a very active process. You'll likely need multiple people, all hands on deck, to make sure we're monitoring and making sure they're doing well. If they're not hot, okay, is it their sodium? Is that what's causing their symptoms? Make sure to get them that salty water, and depending on how well they do with that, maybe they need IV fluids, maybe they need transferred out. And then exercise-associated collapse. This is a diagnosis of exclusion. You have run through those other 3 things, and if you think that this is what's going on, elevate their feet and hydrate. Thank you everyone for listening to this presentation. Please feel free to listen to this again at your own leisure. Listen to it before you come to the marathon. Go through those algorithms. And if you have any questions or concerns, please feel free to email Dr. Supik. Thank you. Have a good day. Bye.